Good afternoon, sir and my fellow friends. Today I'm going to present my case study about iron deficiency anemia. Okay, for abstracts, anemia is a condition where RBC lower than normals, and iron is the essential mineral needed to form hemoglobin, which is hemoglobin is an oxygen-carrying protein inside the RBC. And iron deficiency anemia is a condition where body lacks enough RBC to transport the oxygen-rich blood to the body tissue. IDA is the most common form of anemia. It's developed when body does not have enough iron to manufacture RBC. Without enough iron, body use all stored iron in the liver, bone marrow, and the other organs. Once depleted, body is able to make a few RBCs. If erythropoietin is present without sufficient iron, there is insufficient fuel for RBCs production. The RBC thus the body is available to make an abnormal and do not have a normal hemoglobin carrying capacity, so do normal red blood cells. Of introduction, this is the PBR, iron deficiency anemia, red blood compared to the normals. About 30% of the global population suffer from the IDA. Most cases happen in developing countries. IDA is anemia of disorder of iron metabolism and heme synthesis. The body needs iron to make hemoglobin. If there isn't enough iron available, hemoglobin production is limited, which is in turn affect the production of RBCs. Anemia is decreased amount of hemoglobin and RBCs in the bloodstream. Iron deficient affect infant, young children, adolescents, and women of childbearing age, which diet provide insufficient bioavailable iron to meet their needs for growth, the replacement of menstrual losses, and pregnancy. This case study was limited to detect of iron deficiency only. Overview of IDA cases in KK Chongot. This is overview from 2017, 2018, and 2019. And from the table, we know that the majority IDA cases in KK Chongot is from the pregnant women. This may due to KK. Okay. From the table, it shows that majority ID cases in KK Chongot is from the pregnant woman. This may due to KK Chongot is a primary care clinic, and most of the cases treated here is from the antenatal clinic. Okay, we have one cases here. Case report. A 25-year-old female who is 5'1" and weight 50 kg reported to the physician for consultation. She is a student who claimed to not have enough time to eat healthily or exercise on a regular basis. She complained of generalized weakness, lethargy, and inability to do the routine work from the previous few months. Recently, she had noticed that it is very hard to get up in the mornings and very fatigued throughout the day, and having a short of breath frequently. On further questioning, she revealed that she was having excessive bleeding during menstruation from the previous 6 months. She complained of breathlessness and palpitation while climbing stairs. She also had experienced periods of light headache throughout, not to the point of fainting. Other changes she had noticed were cramping in her leg, a desire to crunch on ice. She always has cold hands and feet, but craved ice on a daily basis. There was no history of any fever during intake or abdominal discomfort. Her appetite has also decreased, and she was taking meals only once a day. She looked healthy, but upon examination, her physician found that she had a tachycardia, pale gum in nail beds, and her tongue was swollen. Given her history and the findings on her physical examination, the physician suspected that the patient was anemic and ordered a sample of her blood for examination. For examination, physical examination is as above. Endoscopy is to allow the doctor to examine the digestive tract for source of bleeding. It was not done. Colonoscopy and ultrasound also not done. Investigation. Routine test is FBC, RBC, HB, hematocrit, MCV, MCH, MCHC, WBC. MCH is low in count, whereas WBC and platelets is normal. Further investigation, iron profile, serum ferritin is low, serum iron low, TIBC is increased, and transferrin is low. Reticulocyte reduced slightly. Further investigation, number 3 is the peripheral blood films. In peripheral blood films, we can observe that for RBC morphology, the RBC show moderate anemia, hypochromic microcytic, anisopoikilocytosis with teardrop cells, elliptocytosis, target cells, and pencil cells. For bone marrow aspiration, bone marrow is hypocellular with polychromatic normoblast predominance. Erythroid series is small and have tiny projection from the cytoplasm. When stained with the iron stain, pearl Prussian blue, this stain show negative, which means less iron. And then further investigation, occasionally investigation required or known as other test, which is feces examination for parasite, and the result was negative for hookworm. So that means that the IDA cases in these cases were not caused by the infection of a parasitic infection such as hookworm. Okay, FBC result interpretation. The FBC test is the primary or routine test that can confirm that the patient has IDA. Low hemoglobin levels show anemia, and RBCs are smaller and paler in color. The MCV and MCH are low for these cases, and platelet count was normal, but sometimes the platelet can increase in the cases of chronic bleeding. Okay, differential diagnosis. To distinguish IDA from other anemia, in IDA, MCV and MCH, serum iron and ferritin is low, and TIBC is high. Bone marrow, iron store in erythroblast, iron is absent compared to the other anemia. This is shown in this table. Background. IDA is the most common nutritional deficiency worldwide. Estimated that 1.6 billion people have iron deficiency anemia. This causes reduced work capacity in adults, can impact motor and mental development in children and adolescents. Women are at a higher risk compared to men because of the blood loss during menstruation and their bodies store less iron. Iron deficiency in pregnant women has been estimated to be the cause of 1 to 5 cases. Iron deficiency in pregnant women has been estimated to be the cause of 1 to 5 cases of maternal morbidity, and almost 40% of all perinatal maternal deaths are linked to anemia. Risk factor is in infant, children, women, especially female of childbearing age or was pregnant twice or more, or long intermenstrual bleeding, elderly peoples, or people with certain condition. Epidemiology. Overall, iron deficiency is the most common reason for anemia. It affects over 12% of the population and more prevailing in third world countries due to the poor diet. Sign and symptom and clinical manifestation. The sign and symptom including fatigue, dizziness, headache, dry or pale skin or pallor, spoon-shaped nail coilicide, like this one is shown in the picture, increased platelet count in some cases, enlarged spleen in some cases, cold hand and feet, frequent infection, irritability. This happens when the hemoglobin level falls to less than 5 grams per deciliter. Irritability and anorexia are prominent. Shortness of breath, swelling or soreness of the tongue, unusual craving for non-nutritive substance such as ice, dirt, paint, or starch. This craving is called pica. Some people who have iron deficiency anemia develop restless leg syndrome (RLS). And RLS is a disorder that causes a strong urge to move the leg. Etiology: IDA usually due to blood loss, poor diet, increased iron utilization, and an inability to absorb enough iron from food, inadequate iron to produce enough HB and RBC that enable them to carry oxygen. This causes shortness of breath and fatigue. Blood loss causes iron depletion. In women, long or heavy menstrual period or bleeding, fibroid in the uterus can cause blood loss. Blood loss during childbirth and internal bleeding. Low iron intake and during some stages of life such as pregnancy and childhood can cause poor diet of iron. Malabsorption in people who have intestinal surgery, parasitic infection. So, treatment. The best treatment is to investigate the cause of anemia in loss of iron storage and treat accordingly. Patient education regarding her new diagnosis, treatment optional in prognosis, and watch for treatment compliance. Correct anemia in iron store with iron supplement taken 1 hour before or after meal with chews. Additional of folic acid and vitamin C. Oral iron treatment may require 3 to 6 months to replenish body store. Diet counseling. Recommend to consume good amount of iron-rich diet. Good source of iron include meat, poultry, fish, leafy green of the cabbage family such as broccoli, kale, turnip green, and collard, and legumes. Medical care. This may only given in a hospital. This include first is parenteral iron therapy. This should usually be avoided because of the side effect that can be severe during therapy. Iron dextran is a stable complex of ferric hydroxide and low molecular weight dextran containing 50 mg of elemental iron per ml of solution. It can be given IM injection or IV infusion. Adverse effects usually develop lightheadedness, fever, arthralgias, back pain, urticaria, bronchospasm, and hypersensitivity reaction. 2. Iron sucrose complex and iron sodium gluconate complex. This only for patients with hypersensitivity reaction to oral iron salts given by IV route. For patients who are treated chronically with iron, it is important to monitor the iron level to avoid iron overload. Adverse effects same as the iron dextran. And the thirdly is the blood transfusion, only used in several cases to replace iron in blood loss immediately. Discussion. Iron deficiency anemia develop in 3 stages. One is iron depletion, second iron deficient erythropoiesis, and lastly iron deficiency anemia. In iron depletion, iron store exhausted as indicated by decreased serum ferritin, serum iron normal. In these stages, there is still no anemia and the erythrocyte morphology is still normal. In iron deficiency erythropoiesis, there is insufficient iron to insert into the protoporphyrin ring to perform heme. Serum iron is also depleted. Anemia and hypochromia are still not detectable. Erythrocyte may become slightly microcytic. In iron deficiency anemia, long-standing negative Blood loss significantly shortened these stages. Classic macrocytosis and hypochromia. The situation represents advanced stage of severity deficient by body iron. Consequences of the iron deficiency is such as long-term mental impairment, impaired immune function, poor physical performance. The best treatment of IDA is diet counseling. Investigate the cause of prolonged intermenstrual bleeding and rule out the GIT bleeding. Educate the patient how to use iron supplement and about its side effect. Start supplementing with iron supplement in conjunction with vitamin C. Iron absorbs best in acid environments. Therefore, any food or medication that can increase gastric pH will interfere with proper absorption. Iron can interfere also with absorption of other drugs. So it is advised to best given alone. For interaction, cereals, dietary fiber, tea, coffee, eggs, milk may decrease absorption. Avoid taking in the other multivitamin or mineral product within 2 hours before or after taking your iron supplement. Avoid taking antibiotics such as ciprofloxacin, dimeclocycline, doxycycline, and inocycline, norfloxacin, ofloxacin, or tetracycline. Avoid antacid within 2 hours before or after meals when taking your iron medication. Conclusion: body iron status can usually be assessed by considering the HB, red cell indices, and serum iron and serum ferritin concentrated, and TIBC. Other tests such as peripheral blood film, reticulocytes, and bone marrow aspiration for demonstration of iron, along with the evidence of inflammation, infection, and liver disease. The best treatment for IDA is a diet therapy and also correction of the causes of anemia such as iron supplement and also other treatment according to the cause of anemic. Okay, my reference is this is my list of reference. And lastly, but not least, thank you.